Good afternoon, ladies and gentlemen. My name is Negahban. I'm currently working in the UK in Barnsley Hospital as a cardiologist. And the case I'm going to talk about today is Takotsubo cardiomyopathy. And the case is unique for that reason. This is first described in the world. So, Takotsubo cardiomyopathy, if I just want to explain to understand, cardiomyopathy is any disease causing impairment of the heart function, and it could lead to heart failure. Takotsubo, why Takotsubo and what does mean? Okay. Is that working? I have to use the... This is not working, I think.
Let me try. He's coming. Oh, you're right.
Yeah. Anyways, I can use the arrows. So, Takotsubo, I think it's not working, just a pointer right here. Takotsubo is the other synonyms which we can use, is transient left ventricle apical ballooning syndrome. Broken heart syndrome, maybe you heard about that, and stress-induced myocardial stunning. So this was described first in 1991, 24 years ago, by Japanese interventional cardiologist Dota and his team. So that's the reason why the name is Takotsubo, because it's a Japanese name. And why he named this Takotsubo, I'll explain the next slide. This down, you see the Takotsubo is here. This is actually a pot with narrow neck and very wide body. So they are in Japan. They are trapping octopuses in this pot. So because the shape of the heart, when it's affected by Takotsubo, is the same like this pot. So Tako means octopus and Subo means a pot. Takotsubo is a pot with, as I explained, a round bottom and narrow neck used for trapping octopuses in Japan. That's why they call it Takotsubo cardiomyopathy. So, on the left side, you can see the picture of the heart, how nicely it's contracting. That's the normal contraction of the heart. That's a simulation of heart. And on the right side, you can see the ballooning of the apex of the heart. There is an angiography, left ventricular angiography here, so you can nicely see the ballooning which is there when we inject the contrast medium to the left ventricle. Then you see the ballooning of the apex of the heart. That's what we call apical ballooning. This is an echocardiography picture, the middle one, and again it shows that there is the apex of the heart here is not moving well. And on the right side, you can see the picture 3 months later. This is the same patient. So you see how nicely the apex is moving now. So this is completely recovery. And that's one of the criteria for Takotsubo cardiomyopathy, because it's reversible, so it's transient. So what is the epidemiology? Is 1 to 2% of cases diagnosed as acute coronary syndrome. Mostly, it affects women in their postmenopausal age. And often there is an emotional or physical stress preceding that event. What is the etiology and pathophysiology of this disease? Unfortunately, you see the locker there that is not clear yet. But there are some theory, which one of these is catecholamine-mediated cardiotoxicity. I'll explain on the picture I hope this works here. No, anyway, I will use the arrow. That's fine. Okay, so I don't want to be too much scientific, but on the right side here, I want just to explain the way the catecholamine normally works. You see adrenaline and noradrenaline. You see the adrenaline sports when you are running, when you are doing something. So the adrenaline normally is released to the circulation. And the effect of adrenaline on the heart is through the protein, which we call it through the receptors, because G stimulating, just that word, stimulating protein, which activate the enzyme, which is a key enzyme, adenylate cyclase, is here, and this converts adenosine triphosphate to adenosine diphosphate, and this creates some cyclic adenosine monophosphate, which is which is a main source of energy for the heart and causing the heart contraction. What's happening in Takotsubo cardiomyopathy? Because we know that this is a very excess release of adrenaline and noradrenaline, that's the normal pathway. And in that pathway, that G-stimulating, instead of G-stimulating protein, there is a G-inhibiting protein which is activated, and that whole pathway is blocked, and there is no contraction. That's what we see, the akinesis or lack of movement for the heart muscles. So the key answer should be here, but it's not still. Still needs some submolecular discussion. So the other theory, the next possible theory is coronary microvascular constriction. So what this means, what supports this theory, is actually the effect of adrenaline and noradrenaline you can see on the alpha 1 and alpha 2 blockers. They are very known thing for everybody that they are doing vasoconstriction, adrenaline we use to increase blood pressure in patient with hypotension or shock, or in patient in shock. Oh, sorry for them. It's a bit. Okay, there is another theory is TIMI, which means TIMI frame count showed impaired microcirculatory flow. TIMI frame count means when we do angiography, it depends how many pictures, how many sign frame you have to take. It's a bit difficult if you don't do angiography, but how many pictures we have to take till the contrast medium reach the distal part of the coronary arteries. In Takotsubo cardiomyopathy patient, this frame count was increased. PET is a positron emission tomography which showed reversible impairment of coronary flow reserve. Coronary flow reserve means when in normal heart, when you're running, when you're doing something, your heart vessel can dilate, can be enlarged up to 5 times. But in patient with Takotsubo cardiomyopathy, that's missing. And there is as well contrast echo showed impaired myocardial perfusion. So what are the clinical and imaging characteristics of Takotsubo cardiomyopathy? For you as a nurses or other clinician, so it's very important. The question number 1 is whether you can distinguish between acute myocardial infarction and Takotsubo cardiomyopathy. The answer is no, unless you do angiography. So patients coming with chest pain, so see the picture, typical chest pain, central chest pain radiating to the neck, to the shoulder. There are ECG changes similar to when the patient coming with STEMI, like ST elevation or ST depression or T-wave inversion. There's a slightly raised troponin, so this is another cardiac marker which is raised in heart attack as well. And there's a transient left ventricular dysfunction, which means the function of the left ventricle is impaired. And Takotsubo cardiomyopathy imitates acute coronary syndrome, so we can't distinguish according to the clinical picture. When the patient is coming to us, we can't say exactly this patient has Takotsubo cardiomyopathy or as myocardial infarction. So frequently is misdiagnosed as an acute coronary syndrome. So the diagnostic criteria according to the Mayo Clinic, these are old diagnostic criteria, but most of them are still valid. So it says new abnormalities on ECG, which means ST segment elevation, T-wave inversion, and cardiac troponin raised. Then transient reversible akinesia or hypokinesia, which means a lack of movement or absolutely no movement of the left ventricle mid-segment, eventually also with involvement of the apex, independently of vascular distribution. There is absence of obstructive coronary artery disease. When you do angiogram, there is no coronary artery disease, as you can see in acute coronary syndrome. And there should be, the myocarditis should be excluded, and pheochromocytoma, which is a known tumor of the adrenal gland, and it should be as well excluded because it's releasing a lot of excess amount of catecholamine, adrenal, and noradrenaline. And original criteria also included the absence of head injury and intracranial hemorrhage. So what is the treatment for that? Symptomatic. So we treat mostly in the world, all doctors or clinicians, they are treating symptoms. Treatment is supportive, which means analgesia, so morphine, any other type of analgesia. Oxygen, when the patient is coming with heart attack, so they need oxygen. Diuretics, if the patient is coming with pulmonary edema. ACE inhibitor, supporting or improving the heart function. Beta blockers, and inotropes and intra-aortic balloon pump in cardiogenic shock. So we have to be very careful with inotropes because these inotropes, as I said, it can cause even more damage. But if the patient is shocky, in cardiogenic shock, we don't have any other choice than to treat the shock because the shock is with mortality of 50%. So we need first to treat. But if we can choose, I personally, according to my experiences, dobutamine is better, but sometimes it's very difficult to keep the blood pressure with dobutamine alone. So what is the prognosis? In-hospital mortality is around 2%. It's not zero. So people are dying with Takotsubo cardiomyopathy if we don't know how to treat. And long-term prognosis is mostly favorable with complete resolution. And recurrent of Takotsubo cardiomyopathy is about 5%. So what are complications? Is cardiogenic shock, arrhythmia, any type of ventricular dysrhythmia, so is ventricular fibrillation, ventricular tachycardia, could be even atrial fibrillation, atrial flutter, or just ventricular ectopics. And pulmonary edema as a pictures of heart failure, where people are coming to the hospital with heart failure. So you see, this picture shows that not every patient or not everybody can get Takotsubo. It's different type of stress, different type of, like you see that monkey or that animal in zoo in the cage suffers from a lot of emotional stress, and this possibly will get Takotsubo. But that giraffe running in the mountain area and after the scrumptious food is not getting Takotsubo. So you see the stress is not, all type of stress is not the same. So the case I'm going to present, as I mentioned, is the first case in the world. So it was published in the Journal of Core at Vaza, and there is as well you can some information got on the Journal of Nursing as well. So there's a 56-year-old female presented to the emergency with chest pain and hypertension after a car accident when she was annoyed due to indecency of the second participant in this car accident. So as routine blood tests were done, so troponin level was raised to 0.48 microgram per liter. Maximum troponin was 0.72 microgram per liter, and the normal value at that time is 0.14 microgram per liter, so it just slightly raised, is not significantly raised. What showed transthoracic echocardiogram on admission showed, this is not a movie, but I want to just show you that there is a posterobasal segment is akinetic in here. That's the arrow shows that here. So this is in diastole, and this is in systole. This is a short axis view at the level of papillary muscles. So ECG, what ECG showed on admission? You can see here ECG that there are, the arrows show that this Q wave in lead 3, there's T wave inversion in lead 2, T wave inversion as well in lead 3. So there is as well Q wave in AVF, so it's inferior part of the heart, and there's T wave inversion as well on the lateral lead, which is V5, V6. So it's inferior lateral, like inferior lateral infarction or heart attack. And okay, so patient, of course, received clopidogrel at that time because this case was first described in 2013. At that time, clopidogrel was the only drug. So nowadays is ticagrelor available. So the patient received acetylsalicylic acid and low molecular weight heparin as per ACS protocol. Then she was transferred to the cath lab for angiography because of that picture, still not clear. And angiography and left ventriculography showed this. So you can see the right, I'm sorry, it's a bit difficult. So it showed that this is the right coronary arteries and is clear, absolutely no disease. This is the right, the left system, left descending and circumflex as well, free of disease. And the ventriculography here, and you can see here in diastole, and it shows that there is some problem in the posterior-basal of inferior wall, and when during the contraction, during the systole, and that part is not moving, the arrow shows that there is a posterior-basal akinesis as it showed on the echocardiogram previously. So, and at that time, an atypical pattern of Takotsubo cardiomyopathy was suspected because it was regional of the posterior wall affected. 2 days later, patient was discharged home on medication, metoprolol, which is a beta blocker, 25 milligram once a day, and acetylsalicylic acid, 100 milligram once daily. And ECG and transthoracic echocardiogram on discharge showed the same finding as on admission. And patient was followed up for 2 months. So then another echocardiogram was performed by the same echocardiographer, and here you can see a bit improvement. So a bit improvement of the posterior-basal wall, slightly improvement during this is again, short axis, the same picture as was before, but, and you can see here as well, during the systole is a bit improvement. And we performed a cardiac magnetic resonance, which is very important to see if there is any scar. If there is a scar, then it means there is a heart attack. So the cardiac MRI showed, this is a short axis view again, and it showed that posterior-basal hypokinesia or lack of movement. And this is a left ventricular output tract or long axis again. So there is no late gadolinium enhancement, which is one of the important criteria to see if the patient has got heart attack. There is a scar in the heart, and there is a late gadolinium enhancement if there is a heart attack. So this clearly showed that there's no heart attack in this patient. So no scar, as I said. And the third transthoracic echocardiogram in 5 weeks' time again, and you see nicely the left ventricle is now rounded and moving very well during the systole, so there is no more damage or no more hypokinesis in the heart. So, and what is as well interesting and is supporting the criteria for Takotsubo is that there's no T wave inversion, no Q wave on that ECG, so complete resolution. So conclusion is the finding in cardiac MRI as well as the complete resolution of ventricular wall motility and rearrangement of the ECG were thus consistent with the first proposed diagnosis of atypical or variant or uncommon type of Takotsubo cardiomyopathy. And this is as a reference if you are interested to read more about that. And thank you for your listening. Any question? Thank you very much.